nice experience once we interact with our colleagues. Special thanks to Dr. Smit sir, who has made this possible. So here in this session, I will try to share my humble experience with calcified lesions. So how I manage my patient with severe calcification. So the most important thing is, most important thing in treating a calcified lesion is doing a good quality coronary angiogram and trying to understand. Sometimes even with the quality coronary angiogram, we may underestimate the severity of calcium. Once you underestimate the severity of calcium, then it is definitely warrant for a soup. The thing it can range from inability to deliver your device. It can result in vessel dissection, no flow, slow flow, cardiac arrest, and it can result in fracture or underexpansion, perforation. So we will try to see some of these complications in some of these patients. So there will not be any lecture slides. All the slides will be angiographic slides, and I will also try to take some input. So you can see here, this patient presented with is a female patient presented with non-STEMI. EF was okay, and you can see this if you have a very casual eye, you can see okay, this is not. This is a type A lesion, right? So go for a direct stenting. This is the reason. And see, during direct stent, you can see the waist is there in the middle of the stent. And this is after angiogram, you can see there is a significant waist. So as usual, that stent was 2.75 into 24 mm des. And this was 3 mm, 14 atmosphere, not I gone to atmosphere. I saw, fortunately, see the vessel extravasated. I have not taken the scene of the perforation. I just, that shot was not fluoro stone. We can see the extravasated dye from the vessel. So immediately I injected up to 12 atmosphere with the same balloon, and by prolonged inhalation, luckily perforation would be seen. What is the learning lesson from this patient is that never underestimate hello.
Yeah, Velu, lot of
yes, sir.
trailing and breaking. I think I'll request the tech team once again to check.
Yes, sir.
Yeah, you are correct. Connection is just interpreting, sir. So that's why your voice is breaking.
Okay. Can I continue?
Yeah,
My
sure.
slides.
Please, sir.
Okay. Okay. So one of the nastiest complications of underappreciated calcified PCI perforation. So that can happen at any time. Even you may think that it's a 3 mm balloon and you have not gone too far. Still the cell can perforate, right? Slides are not moving.
I think, Velu, if you put off your video and just do audio, maybe you'll get more bandwidth over there.
Yeah, that's a good suggestion.
Sir, but my slides are not moving. Just stop share, go to the next slide.
You can reshare them.
Just a minute.
Yeah.
Yes, sir. I'm just trying to reshare.
And meanwhile, click the start video button. It will stop video next to mute.
Sir. Yeah. Yeah, I think so. This is the second case. So he's a middle-aged male who presented with unstable angina. Ejection fraction was okay. So as you can see here, he had triple vessel disease, and there are long calcified starting all the way from proximal LAD to distal LAD. The diagrams are visible. Also, RCA also showed a long segment calcific disease. So what will be the best management in this patient? So this patient initially was saying they're not willing for. So I have given them the first option and the second option being the coronary artery bypass surgery. They were not really willing, but I've pushed them, and after repeated counseling, they have they become willing for coronary artery bypass surgery. So the most important thing in treatment of calcified is always sorry for the interruption. I don't know what's happening. Okay. This is a 76-year-old male presented with non-STEMI with ejection fraction of 45%, and RWMA of LAD territory, and he had severe refractory COPD. Both the CABG team, CTVS team, and the patient parties were not willing for open heart surgery. So as you can see here, the angiogram showed heavily calcific proximal proximal to mid LAD disease. Also, the ostial LMC also had significant disease. Can very clearly see here. So this patient was the angiogram very clearly shows calcification. So in such patient, you can see even the microcatheter, the fine cross is finding it's very hard to cross that lesion. So that it was changed. The rotafloppy wire was parked across the distal lesion and kept in the distal LAD. And since fine cross could not cross the lesion, rotabar 1.25 mm was taken. If the lesion could be crossed easily with fine cross, then you can use a 1.5 mm burr. Because sometimes if you can't cross it with fine cross, then you may find it difficult to cross with 1.5 mm burr, right? So after rotablation, predilatation was done from 2 and 2.5. So the lesion preparation, this was the angiographic picture. And you can see the IVUS, the tightest spot showed MLA of 2 mm square. As we know, it's very, very significant tight disease. But you can see there are fractures can be noticed in the longitudinal section. So you can see the dense arc of calcium here. It's more than 180 degree. I can more than 2/3. So these were the IVUS findings. At the mid LAD had the tightest stenosis with dense calcium. So after lesion preparation with rotablation and NC balloon dilatation, mid LAD was stented with 2.75 into 38 mm DES. And the ostial LMCA to proximal LAD was deployed with 3.5 into 32 mm DES. And this is the final cine after, this is not the final cine, the initial part was done with the 4 into 12 mm balloon. You can see that mid LAD lesion has given away nicely. And you can see here, refined post dilatation was done with 4 into 12 mm balloon at 16 to 20 atmospheres. And the post dilatation IVUS was done, which findings I will share. And final part was done after the IVUS. It was noted that the left main alone 4 alone is not enough. So I took 5 into 8 mm NC Sapphire, and at 14 atmosphere there was a satisfactory result. You can see here the result is really good. And the IVUS post PCA in the mid, where we had only 2 mm square MLA, the MSA was 8 mm square. And in the proximal, it was satisfactory. It was 10.66 square millimeter. These were the IVUS findings after the final post dilatation. The same patient, the RCA had this lesion heavily calcified. You can see the track appearance very clearly in the angiogram. If in this patient, if you are going to do away without preparation, bed preparation, then we are going to be in for a soup. There's going to be an under expansion, because when we start off the practice in the initial 1 or 2 years, we may think that this lesion is a very easy lesion and it may easily give away with NC balloon, but more often it doesn't. So we often land up with inadequately expanded stent, or we land up with high pressure after stenting. The key in treating calcified lesion is always prepare the bed nicely. That is the most important key. The first important thing is do a proper angiogram, take as much as pictures allowed, and always try to do an imaging. But in my center, we don't have OCT, so we always should render an OCT and do. But we have an IVUS. More often we use it. And here, very clear in almost all and you can see here in the last, there's a very tight mid RCA, heavily calcified lesion, and it was decided to do 1.75 mm burr. This patient, actually, he was some 74 or 75 years, but after doing the LAD, this RCA procedure could have been staged, but this patient was very adamant that he told he will come for procedure only once. He cannot come for the next time. And we also thought that we could cut down on the finances because we could reuse balloons because he had borderline finances. Though we used two types of 1.25 mm burr in the LAD and 1.75 burr in the RCA. But having said that, this is not the ideal way to do. Always stage it on 2 different days. Never do rotablation in 2 different vessels in an elderly, frail patient, because this patient more often is going to have some form of complication. In this patient, after the first run, he had a significant hypotension, which recovered with ephedrine. And you can see there is a pecking movement with the 1.75 mm burr. But you can see here, nicely it gone off. I think this is not the initial run. The initial run should never be done like this. This is either probably second or third run. Initial run should always be slow pecking movement, go, come back, go, come back. And this is after rotablation. And after adequate pre-dilatation with 3 mm NC balloon, so 3.5 distal RCA also had a lesion which was stented with 3 into 24 mm, and proximal to mid RCA was stented with 3.5 mm long stent. And post dilatation was done with 4 into 12 mm balloon at high pressure. And this is the final pictures. So you can see the spot at which the tightest calcium point at the mid RCA yielded really well. This result you can never get without adjunctive therapies that can ablate the calcium. So either you should use IVL or you should use rotablation, but this patient couldn't afford IVL. So the take-home message from this patient is that always pre-plan. Then you should not have a, this is known as rota regret. So you should always plan and take the rota ahead rather than taking high pressure balloon and ending up with nasty dissections. I have case examples of what has happened. This is another case, middle-aged male with crescendo angina. EF is okay. Somehow I have pushed him for CABG, but this he was really adamant. He agreed to angiogram on only one only one condition, that if there is going to be lesion, it has to be stented. He's not ready for any kind of open surgical intervention. So after this angiogram, despite all these things explaining everything, you can see RCA, this mid RCA has a tight lesion followed by there is a hazy lesion. So to me, it was mostly of thrombotic lesion rather than calcific lesion rather than a thrombotic lesion. And you can see here LAD is also pretty much calcified. You can see angulated, highly complex calcified lesion. OCT, if it could have been done in this patient, it could have revealed a beautiful images. But since we didn't have OCT at that time, I couldn't use it, right? So I thought I will finish off with the RCA first, then come to left system. So I thought initially, okay, we will do with the 3 mm NC balloon with over a buddy wire, because we all know poor man's cutting balloon, or sometimes it gives nice results. So what I thought was, if I couldn't do with this, then maybe I could use an IVL balloon, right? Because we had an IVL arranged everything at that setting. Because we had an IVL workshop for another patient. Luckily, the IVL people were there, and for him it really helped, especially in the left system. So for the right system, with this buddy wire, over the buddy wire, NC pre-dilatation, high pressure pre-dilatation itself opened the lesion significantly. And he was stented with 3.5 into 38 mm DES. And after high pressure dilatation, you can see the lesion has post dilatation. There is no waste, and there is a reasonably okay result in the right system. Coming to the left system, you can see this very clearly. You can see this heavily calcified, an angry looking lesion. So please don't underestimate such lesions. So which I have done initially, I've thought, okay, I'll go with increasing size of balloon, 2 mm, 2.5, even with 2.5 mm, you can see here, there is a waste, right? But what happened is that it has resulted in, then IVUS was done. It resulted in a dissection. You can see here, the vessel was dissected. Honestly speaking, I don't have guts to do rotablation in such an angulated lesion with dissection. So it was decided to use IVL in this patient. So intravascular lithoplasty really helped. You can see here, it has opened up that angulated calcific lesion. 3 into 12 mm IVL, and almost all the 10 pulses are given in the region of this calcific from mid LAD to proximal LAD. And 3 into 38 mm DES was deployed because there was a size mismatch from the proximal LAD can be really, it's a 4 mm, but in the mid LAD in the landing zone, it was not. From imaging it was maximum 3.2. So I don't want to produce a dissection there. So I took 3 mm stent, then post dilated with 3.5 and 4 mm. And you can see here, there is no waste in the region of maximum. There is this lesion, the yielded really. And this is the final epicranial view showing a nicely expanded lesion at the tight spot. And here, this is the epicaudal view showing reasonably a good result according to me. And even the imaging didn't find any significant under expansion or this thing. This is another patient, 74-year-old male with recurrent non-STEMI, recurrent episodes. He was kept on, kept on medical management. He was a smoker, bad lung, ejection fraction was 40%. Every time he presents with non-STEMI with pulmonary edema, RWM of LAD tertiary valves were normal. CAG was done after multiple prolonged OMT. Actually, OMT could not be achieved. Despite OMT, he is having multiple symptoms. Both the patient and the CTVS team were unwilling for CABG. Also, the cardiologist is not willing for PCI in this patient because of his horrible anatomy. So you can see here, the distal left main, there is a lesion involving the distal left main and the ostial LAD. And you can see here, the ostial LMCA is also having a significant tight disease. There was damping. So this thing can be missed when you do angiogram by a 5 French tiger from the radial route. So very important, when you see a lot of calcium in such patients with recurrent pulmonary edema, non-STEMI, you should not miss ostial LMCA lesions. Very important. Because that can be overlooked by doing an angiogram from the radial route with a 5 French tiger. See here, there is a very lazy lesion that LMCA producing dampening. So I am removing the guide from each and every injection. Also, the RCA is also showing a nasty calcified mid RCA, highly calcified lesion. So what I thought was, okay, this patient is too sick, so I will not use any therapy, adjunctive therapy, because what I thought was he may not tolerate rotablation. This is honestly I thought, but the learning lesson, I will tell you the learning lesson from this patient. You can see this first, you can see the calcium, you can see the carinal calcium, and you can see there is a calcific bifurcation. It's very nice. At least after looking this angiogram, I should have decided form of adjunctive therapy. But this patient had real cost constraints, right? He was an ECHS patient. And I thought, okay, I will try to pre-dilate with balloon and I will go for all things. But after this balloon dilatation, patient went in for hypotension, severe, he complained of severe chest pain, hypotension, and arrested. So what happened is that lady, because it is like a tandem lesion, one in the distal LMCA, one in the osteal lady, and the balloon did not yield anything, but it has dissected in the osteal lady and the no flow and arrested. He was intubated, CPR done, and again repeat pre-dilatation was done. Again, you see very clearly the waste is here. This is the calcium, and one was going beyond this. You can see slow flow. This is the lesion. So I thought giving stabilization, but no stent was going. The best had flat. So patient was crashing. Luckily, the flow came, and since the rotablation also, we don't know what is the extraction, all those things. I thought I took a score balloon. I asked for 3 mm score balloon, but there was no 3 mm score balloon. I took 2.75 mm. But you see waste here. Waste. This waste was not going. 2.75 into 10, we gone up to and this ruptured. This balloon ruptured. You can see waste was not giving, ruptured. Again, he developed slow flow. Again, rust. Again, yeah, all cocktails, everything. But finally, God's mercy on me and upon the patient. And after taking the 3.5 mm balloon, it partially opened. The vessel partially opened. But once the vessel went, the vessel grew like anything. Initially, from somebody looks at, and even if here, if you see, if somebody asks me what stent you will put, I will say at max 3 mm, and what position something maximum 3.5, especially before this 3.5 mm. But even after this post dilatation, the best of best end was not going. So the guideline itself. So I thought I will put 2 stents. To the guideline. So in the middle lady, it was 3.5 mm desk from to Australia. 4 into 12 mm desk was implanted. This is after post dilatation. You can see post dilated with 4 and 4.5 mm. Even 4.5 mm was used to the sectasia. The sectasia segment grew after the vessel has grown like anything. Once that calcium away, the vessel has grown like anything. This is one of the important things. After lesion preparation, good lesion preparation, we have to reassess the vessel size and calcified lesion, because many times this calcified will look undersized. And if you done good preparation, and if you've given good cocktails, and if you see the vessel size more often changes and imaging more often helps. But in this case, the patient didn't give time for imaging or any. The fault is entirely because of very, I despite knowing there is a trampra calcium, all those things, I thought that I was because I thought this patient got arrested during ablation. But in hindsight, this is one of the cases of rota in the initially, because if rota would have been taken, that one spot would have given nicely, that would have been shaved nicely, that would have been ablated nicely, and things would have been very smooth for this patient. So the most important, this is done in November 15th only, and this patient had a EF drop because of the periprocedural myocardial from 40%, but he was extubated the next day, and he was discharged, and his discharge EF 45%. Another male, 27-year-old male, again non-TME injection process okay. By the surgeons. You can see here again. You can see here osteal MCA, the heart disease, and the proxial significant tight disease. And you can see here, this is angulated lesion. When calcium acts to tortuosity and the corresponding angulation, there's so this is another second patient. I have to 77-year-old male with this is a septuagenarian, and he had a very tight angulated calcified disease. So this now we have a newer this thing RotaPro, which is very user friendly. We don't need to use your legs for doing this. Everything has become very handy with the hands only. And this patient RotaPro was used to ablate the lesion. And one thing is that angle I could not ablate it very effectively with this technique. So by pulling the wire, you can so this is a classical example of doing ablation. The angulated lesions can be really taken care of. So, hello, Dr. Smith, sir.
Yeah. Hello.
Okay, can we proceed?
Yeah, yeah.
I can hear. Yeah, but somehow some virus popping up from the link which you have sent. Netcast share, no? Some virus is popping up and okay. So this the middle slide is the example of giving bias using the Rotalink. The rest of the thing is straightforward. Solution yielded and centered and post dilatation. You can see this is the post 3 NC, and you can see the final picture is not bad. It's okay. Probably we cannot achieve this because we always have that ugly angulated some will be there. This is the best that could be achieved if and at the same time don't aim for too much perfection, because if we have too much perfection in calcification, then we will end up in perforation more often. This is an okay result. So I will let me talk. We can have some discussion. Smith sir, are you there?
Yeah, I am there. You know, lot of voice skipping and video skipping is there.
Oh,
Lot
so
of
I have finished my talk. I have shown
Yeah.
Yes, sir. I've shown some case of
I think,
rotablation,
I
cutting
think
balloon.
we have we had Dr. Bali sir also with us. So we all can join. We have Naveen, we have Saurabh, we have Dr. Hariram, Dr. Shastri. So we all can join. And there are few things. One is that, does, size of burr helps in reducing slow flow?
So there is a lot of definitely, sir. They say it should not be. It should be ideally 0.8 burr to vessel size ratio.
Yes.
If it is going to be 1 and above, obviously you are not going to use. But if it is going to be the higher the burr size, the more chances of slow flow. But at the same time, if you are going to undersize a burr, then the chances of stuck burr are going to be high. So in most of our cases, it is 1.5 mm burr in more than 70% of our cases. Very rarely we use the 1.75 mm burr is very rare, and I have not used 2 mm burr, and I don't think 2 mm burr is available. I don't know whether we have 2 mm burr in India. I don't know. 1.25 mm burr, only one indication. If the fine cross is failing to cross, then it is safer to use 1.25 mm burr than to use 1.5 mm burr.
Dr. Bali sir is there. I think we can have his opinion also. Sir, good evening.
Very good evening.
So good evening, sir.
Very good evening, and it was a pleasure listening to the various cases and beautifully done, and plaque modification and beautifully demonstrated by both rotablator and IVL. It was absolutely nice hearing to Dr. Vadivelu.
Thank you, sir. To get the word from you like this is really, I'm blessed today to have such a nice words from you, sir. Thank you, sir. So which one, sir? So if you don't have OCT, should we wait for OCT and do the calcified lesions with OCT, or with IVs only we can get away, sir? Or...
You asking me, or you asking Dr. Vadivelu?
No, sir. I am Vadivelu, sir. Asking you, sir.
Okay. No, I think iOS is extremely well. It tells us about calcium very, very beautifully. And that's quite okay. There is no need for an OCT. Either of the two can be used. There are certain indications where only OCT should be used. And there are indications where only IVS would be useful, like the left main ostium and other areas where OCT will not give you very good information. But in majority of the lesion, I think both give very good information. And in calcified lesion, IVS is good enough. There is you should go ahead and do it. The only point I wanted to know from you is that do you take into consideration the extent of calcification, the scoring system which we normally use before you choose either a rotablator and IVL, or because I thought that there were a few cases where finances were a constraint. If we forget about that part and look only on the academic component of the evaluation of lesions, do you use the arc of the calcification? Is it 270 or 360, or what is the breadth of calcification, depth of calcification, and the length of the lesion to decide whether you're going to use a rotablator or an IVL or a combination?
No, sir. Practically, I have not been using, though there have been very set guidelines there. I have not used in my patients, because most of the patients they automatically fit into, because they're extensively calcified those things. But I have not used the criteria to differentiate between the OCT, between the rota and the IVL, sir. IVL only in 2 cases I've used, because here in our setup, the affordability is much issues.
My experience with rota is very limited, sir. I have never used it, so it is that limited. But IVL, we have used it very often, and I find IVL to be very safe. There is no concern about slow flow. Only part is trackability, and if we are able to track that balloon, heavy balloon inside, it works very well, sir. So far, it hasn't. has not failed me once even. And the dilatations are very good after IVL. When we try to dilate, prepare the lesions, it gives way very easily. And Rota, my experience is zero. So I don't know.
So what is your take home on the newer terms they are using, rotatripsy, razor tripsy? They use multiple, even the same lesion, they use both rotablation followed by IVL. So
that we have also done. So our first laser case was laser followed by lithotripsy. And that was just to facilitate the tracking of the lithotripsy balloon. So that is one thing. And I think rotatripsy has been done by Anupam. He was also, in his visit, he was sharing it that it also helps. Basically, a IVL balloon, if you can deliver it, it works well.
Smit, two issues with the IVL balloon. One is obviously cost factor we take away. One is the trackability, which you very rightly mentioned. The second is that it is going to take time. You have to deliver multiple shock waves. And if we are doing a left main or an ostial LAD or a critically narrow vessel, which is supplying a large area of myocardium, then you can have patient may not tolerate it. So that is one area.
Yes.
Other thing is these two, and there are case reports where a VT has been precipitated by an IVL, so that is a few case reports. The other thing is, IVL takes care of the deeper calcification also, whereas Rota will take care of mostly the superficial calcification. So you can have a very thick calcification where you might have to use both. IVL and first a rotablator and then an IVL to completely make the bed. That is where the role of imaging comes in. That you've done a rotablator and you still feel that there is a significant calcium in the media, which needs to be tackled, and you are not produced a good amount of cuts, and then obviously IVL also will. So shock tripsy is rotatripsy is a very good modality in such cases.
Yeah.
You do come across such patients which have extensive calcification. So combination is good.
So my wish to understand that whether we use a smaller burr and just track the IVL balloon is enough. Like Velu used 1.75 burr and then it resulted in a very slow flow. So is it just that we can track another balloon inside and crack the calcium is better than upgrading to a larger burr size?
No, 2 points here. One is that, as Dr. Velu very rightly said, that 1.25 we don't use. Most of the time we use almost 70% plus or maybe even 85% plus. We use 1.5 millimeter burr. Sometimes there can be a wire bias also. And therefore, if you use another burr, you may be able to ablate it in a much better area. I have not used this technique which you are mentioning, that you use a smaller burr and to make a way for an IVL. Because if you're using a burr, then you want to get the maximum benefit out of that burr also. So it's a good idea to go ahead with the 1.5 millimeter burr because the entrapment would be much less than what would be with 1.25, and do as good a job with 1.5 millimeter burr as possible. And if after that you are not able to get good crack in the calcium, then you have a choice either to upgrade or to use a lithotripsy. That I think would depend on the affordability and the logistic component of that. So most of the cases we use a 1.5 millimeter and then go to a lithotripsy rather than upgrading to that. But alternative of upgrading to 1.75 is also a very good way of going about it. And I haven't used 2, and I don't think 2 is available in the country, and I think rarely should be used. The bigger the bar, more chances of slow flow and no flow.
Yes. Rota in dissection, sir. What complications we expect and how to get away with those complications?
See, rota dissection used to be a huge problem about 15 years or 10, 15 years ago. And it was general teaching at that time that once you're done a rota, don't go with a high pressure balloon dilatation. Try to get only about 8 to 10 or a nominal pressure after you have done a rotablator. But now with the improving understanding of the way rotablator acts, so you can do a rotablator and then go with the balloon dilatation and the dissection is there. It will depend on, how extensive the dissection is, what is the depth of extension, and it can be taken care of. I don't think it's such a huge problem. But occasionally, yes, complications are there. Slow flow, no flow obviously are the commonest. But dissection, which can be very bad, or even a perforation, are important problems. So I think there's a good long learning curve for rotablator as compared to any other modality of treatment which you take care of. So one should spend some time with people who are doing rotablator and understand the nuances of rotablator, and then it becomes a very, very smooth. And I think once you start doing rotablator, the way this balloon tracks and the stent tracks, you would like it. So it's a good idea to learn it and practice it. The rest, Dr. Velwood can add to what I have added.
Yes, sir. Really, sir, because initially when I was worried in using rotablation, Dr. Nagendra Babudi used to come. Then under his proctorship, started learning slowly. Then started actually, because upfront rota saves a lot of time also and saves a lot of actually, in the one of the cases I have told, I thought taking a rota might harm the patient, but it's the other way. Without rota, I've taken a NC balloon which has dissected proximal to the calcium, and the LAD stopped. No flow in the LAD patient arrested. So if I had taken rotablation, it would have been a very safer and simpler procedure. And so in selected patients, rotablation produces safer results. The only thing is, initial 6-7 cases, we have to get some proctorship. And this RotaPro has become very handy. You don't need to use your legs. Like rotablation is the only instrument in interventional cardiology where you have to use both your hands and both your legs. Because one pedal for fluoro, one pedal for your rota pedal, and one is for your this ablating. The other is to hold the guide steady. But with RotaPro, they have made it very easy. You don't need to use like the conventional rota. Sometimes you feel like you're dancing, but with this RotaPro, it has become very handy, and even the it has become less resistant. I can say it is very smoother.
So for people like me who are trained on the old rota, we are finding it a little difficult to transition to RotaPro, because now we've figured out how both the legs move and how the hands move, what you're supposed to do. So I think my 2 bits about rota is like this, that the burr size is dictated by the receiving vessel size, number one. And since we are now looking just to modify the plaque, the burr to vessel size ratio should not exceed more than 0.5. And if you do not exceed 0.5, you're rarely going to land up into major complications like slow flow or major regarding I have used, if there's and the reason that we use 1.5 most commonly, because most of our vessel sizes are less than 3.5. But if you have a 3.5 or larger receiving vessel, a 1.75 burr will do really well. And by doing 1.5 in a you will not be able to modify the plaque. Sometimes if the lesion is extremely tight and you're not able to cross with 1.5 or 1.5 is, then using a 1.25 vessel burr to get across and then upgrading to 1.5 also can really help. And we had, 8, we recently presented, one of our juniors presented 8 cases of rotatripsy from our center that we had done. And like Dr. Bali pointed out, these are the lesions where following rota, inadequate, yielding of the vessel, too much of calcium, and then we went to IVL. But I find that in most cases, the IVL hype is a bit over, and we really find that actually maximum amount of calcium with cost saving, and if you're comfortable with rota, you're able to tackle with rota. That's been my experience, at least. Initially, we were very excited about IVL, and yes, these factors did come about deeper calcium and easier to deliver, but cost is a big constraint. The profile of the balloon is sometimes an issue, And if rota is, you're not inhibited about using rota, then I think we're all, I mean, those of us who are comfortable with rota find that rota will do the job in more than 90-95% of the cases. What do you say, Dr. Bali? How do you feel about IBL?
I think I agree with your point that rota should be the first to go to technology for plaque modification, and everybody should have good experience of using it. I don't
unless you have, say,
part.
very angulated vessels and, rota or single surviving vessel where, or severe LV dysfunction where rota is really a big contraindication, or you have done something and produced a dissection and you're worried about, otherwise I think going to rota will be.
2 points. One is that the threshold for using rota should be low.
Yes.
And it should be an upfront technology.
Yes.
Rather than you go with a high pressure balloon, produce a dissection, and then still the calcium is not giving way, and then you end up with a rotablator. So that should be avoided. So it should be used early. That's one point. Second point is that I have not used this technology of first using of 1.25 and upgrading to 1.5. I think 1.5 works in most of the cases.
Definitely.
And the problem is that we use the term plaque modification, right? But we are actually, in addition to plaque modification, trying to fracture the calcium as well.
Yeah, I mean, by that we are trying to fracture the calcium.
So therefore, 1.5 would be a good idea. And if you're going to use 2 rotabar, that is going to add to the cost as well.
Definitely.
So the first should be 1.5 millimeter in large majority of patients, and the second bar is rarely required. If you are not able to cross with 1.5 millimeter bar, then sometimes you go to a higher revolutions. And that, although the chances of producing a no flow increases a little bit, but with experience, that if you use higher revolution, you are able to get the bar across and modify the leak.
And this fear or this nightmare of having a stuck burr. So if you're careful with your technique of using pecking and, not being forceful, being aware of the sound of the, how the rota burr is, if you get a high pitched whine, you're in trouble. So, these are the things on the learning curve, the finer points that you learn as you go along. And fortunately, I know how to retrieve a stuck burr, hopefully, but fortunately, I've not had to do that as yet. And I hope I never get into a situation. But I've seen
whereas it is a science of angioplasty, it is actually art of rotablation.
Yes, very true. It's an art of angioplasty also. I mean, every science ultimately ends up in an art.
Okay. The reverse.
Yes,
science is what we can explain in the art.
Yes, true.
But absolutely wonderful cases by Dr. Vadivelu.
Wonderful, lovely, really nice. I just wish the internet connective bandwidth was a little better because I was finding it a little difficult to. But
I missed a part of it, but that was because of internet.
The other thing I feel is that how we all start with an angiogram, which is a very poor assessment, gives us a very poor and gives us an under assessment of calcium. And sometimes because of cost, because of so many pressures that we are faced with, we want to guess that there is not enough calcium, and we start doing some procedure, and then we realize that we are in trouble now. So one of the techniques that I use is I use a balloon boost, which I think enhances the angiographic visualization of calcium by at least 40 to 50%. And if you just put an uninflated balloon across the spot where you've got calcium and take a stent boost, it gives you a much better appreciation of what you might otherwise miss on plain angiogram. And then that helps me to think whether I do need to, do some plaque modification or do rota. That's some technique that I feel if you want to, before you go to IVUS or before you go to this thing, maybe balloon boost might be a useful thing.
Neeraj, 2 points. One, if you're doing a complex angioplasty, be it heavily calcified, diffusely disease, vessels or a left main bifurcation, I think imaging should be available.
Yeah,
I think we should start using imaging more often.
What about, Vadivelu showed the first case that it looked like a common garden type A lesion in an OM. I don't know whether you saw that. And then you just get, you thought thoda calcium hai, and then you can do this in half an hour, and then you realize that you're really stuck. So definitely left main complex lesion, you must use imaging, but in some situation where you are not really anticipating, you're not really prepared, because at least we are not doing imaging in all cases. And I don't think
So at least
anyone.
I think 40% cases should be imaged. The type of patients which we're seeing, all of us are seeing now, I think about 30 to 40% patients should undergo imaging. And complexity, the more the complexity, more the need for imaging is there.
Definitely.
The other point
Tell
I
me, sir,
wanted to
one thing,
ask
sir.
you, Dr.
I
Neeraj.
want to ask you one question.
Yeah.
You know, many of our patients, and we also tend to tell the patients that angioplasty is a simple procedure, and patients also believe that. But as we know, we are dealing with very complex lesions and, having to use adjunctive devices and all. So a lot of counseling of patients, and for them to appreciate that there is maybe a cost which comes to it, not only in terms of financial, but also morbidity, and they have to accept maybe some mortality cost. It gives us a lot more comfort, but we tend to, dumb down our specialty, I think, far too much, and just tell them, "Arey, abhi khatam ho jayega," and which is not a good way. At least I feel so. I don't know whether others are feeling. And
I think I couldn't agree with you more. 2 points on that. One is that I think such procedure should not be done ad hoc. It should be an elective procedure, unless this person is in cardiogenic shock, or you're doing a salvage procedure, or you get an attenuation and marker infarction, you find calcified lesion. All those are rare exceptions, but by and large, it should be an elective procedure. Second, comprehensive discussion with the patient and attendant should be done, and I think we should get an anesthetist involved in such procedures. Just keep them on hand, and also get a surgeon to give their opinion that surgical risk is very high, and let them put it in the file that it is a very high surgical risk. And after explaining all these factors, I generally like to talk 2-3 times to the patient and attendant. And if they have any of their doctor or any family member or anything, have him speak to me and explain the entire procedure, and then only proceed with such patients. Still, general public feels that angioplasty is an outdoor procedure. That concept has to change, especially with protected angioplasty coming along, and the type of lesion which are no option patient, which more and more are undergoing angioplasty stenting. It is important that we have a comprehensive discussion with the patient, attendants, and everybody, and involve the entire team to be there and available in the cath lab, and ask for help. There is no problem in asking for help from your colleagues or even intensivist in managing such patients. So I couldn't agree with you more that we should ourselves first try not to undermine our procedure,
yes,
and not belittle the
Yes.
complexity of the experience.
Sir, one final question, sir. Though we are running out of time, when we are doing L6 rotablation, I have never done. I'm always worried of doing rotablation in L6, especially the angulated L6. Any tips and tricks to safely take that bend from left main to L6? Because in most of the patients with calcium, the L6 is more often retroflexed. Should we put a guideliner, then go take the rotablation bar, or what should be done with?
If the lesion is distal to the circumflex ostium, then you can take a 7 French guide, which you normally take, and take a 7 French guideliner, and through that you can do rotablate the distal segment. And obviously, which is extremely tortuous calcified vessel, it may be a good idea to avoid rotablator in such cases, because the complexity does increase the complication rate with rotablator. Those may be the ideal lesion where IVL is very, very good. But a guideliner is very good to use in.
The only perforation that I've had in doing rotablation is doing a circumflex rota, trying to get it across the bend, and it perforated. Fortunately, this was a post-CAVG patient. So the patient did not, there was no tamponade and the perforation sealed off. But this is absolutely a very important point, that doing a rota of an angulated circumflex should safely try to deliver the burr without rotation across that ostium, especially if it is angulated, before you start burring.
Okay.
Good evening, Vali sir and others.
Yeah, Dr. Shastri, you can.
I'm Shastri here.
Yeah.
Thank you, Dr. Vadivelu. Nice presentation, though we missed part of the clips. I have a few questions. How do you? I'll just ask all the questions, and probably you can take up any one. How do you deal with the calcific nodule? That is one. And as rightly Dr. Vadivelu asked about the circumflex, sometimes the distal RCA after the bend, after the acute marginal and all, do we dare to do it? And how often, when you do rotablation or any of these things in the same patient with multiple lesions, multiple vessels at the same sitting, or in the single vessel also, if there is a block burden is enormous, there is a fear of periprocedural MI. That is one question. How do you do that? And how do you take care of the wire bias? That is, and final question. Suppose you have a dissection with a non-compliant balloon, say for example, and in that situation, does it work like a cutting balloon, though it's a crude way of fissuring the lesion, slicing the lesion? Can we go ahead and implant a stent and do a post dilatation, or still do we have to do some IVL or something after once you have got a dissection and the calcified block is there? That's all, sir. These are some of my questions. Bali, sir.
No, I think first let Dr. Vadivelu answer those, because it is his presentation, and let's listen to him first, and then if a little bit we have to add, we'll do that.
It's like a lot of questions have been asked. I think it's the entire textbook can be written. For calcific nodule, studies have shown that IVL is better and better in achieving greater result compared to rotablation. Especially the eccentric calcific nodules, they are very different. The beast, very difficult to treat, and they are notorious for perforation on the opposite side. If you are lucky, though I don't have much experience, if you are lucky, if the wire bias favors us and towards the calcific nodule, rotablation may work. More often we have to take a larger burr, but IVL is the, I think to today until today, the best technology to handle calcific nodule is IVL. And regarding the distal RCA rotablation, I have not done, but I've seen people using a good guide liner. They take the guide liner through inch forming technique, and they place the guide liner somewhere just before the calcific region, and they do it safely, thereby avoiding all the bends and traps. And once you have a dissection in the NC balloon, then it is, as Bali sir has rightly told, it's better. Though people, though Ajay Sami sir has shown multiple, he has a library of rotablation cases, he has shown multiple cases of nasty dissection, but he has done successfully rotablation and salvaged patients. But it needs a lot of learning experience and guts. It is better to use cutting balloon. If the flow is closing down, if patient is crashing, then I think it is better to stent, establish some flow, then use other OPN or something like that. These are the questions I remember. I forgot all the questions which I've asked.
Yeah, very nice. How do you take care of wire bias?
So wire bias is, I don't understand what you introducing a wire bias. Sometimes if you want to apply,
suppose wire bias doesn't favor you.
Yes, sir. That one case I have shown, sir, you have to slightly. There are. I don't have much experience, but Bali sir and Neeraj Bhalla sir can explain. But the commonly used method is you can just slightly pull the rota link wire, then you can ablate it. But you have to be very careful in doing so. The rota bar should not go and touch that radiopaque marker.
And the last question is, if there is a very bulky lesion, large erythematous block, I feel we should avoid, because the chance of periprocedural MI is more, and maybe I don't know how you deal with it. Probably more than rota, IVL may be more beneficial, or doing accepting something with if possible, with a drug-eluting balloon and not to put a stent. I don't know. This is an open question. That's all.
Yes, sir. Periprocedural MI is more higher in rotablation compared to IVL. I think they have compared it in one of the studies where they have shown that the periprocedural MI is more common with rotablation than with IVL, because the peripheral embolization is not a phenomenon that is known to occur in IVL.
So that's what I'm saying. If it is a very bulky lesion, long segment bulky lesion, I think you should go for IVL and cutting balloons than rota. That's what I was intuitively.
Yes, if patient is affordable, then two things. If patient should be affordable and the balloon should be deliverable. If these two things come along, then IVL is definitely a better technology and easier to use technology than rotablation.
I think I'll agree with everything Dr. Vadivelu has said. Only one point which I like to say, that if you have a dissection and it's a bad dissection and it's a calcified lesion, I would go ahead and use all types of, either a cutting balloon or a high pressure balloon dilatation or OPN before I, even in a dissected artery, short of rotablation, and then go ahead and put in a stent. If we put in a stent beforehand, it may not expand nicely and you may have problem at your hand. So even in a dissection, go with a cutting balloon or a high pressure balloon dilatation to get a good dilatation before you implant a stent. Dr. Neeraj?
Agreed, sir. Agreed. I think, following rotablation, how you need to do is use either a cutting or a high pressure balloon and then go ahead and then implant the stent. I think, if I got that. I was actually thinking about, wire bias that Dr. Shastri was pointing out. So I went for some time to Japan, and one of the operators there, what he was doing was he was burring at the highest possible speed, that is 220,000. And he was of the firm opinion that it's only when you use the highest speed that you get the burr to actually track along the wall completely, and you do achieve maximum plaque modification. So although we are now, this was something that was a new thought to me, but he said that unless you do that, you will not get, and that's because of the wire bias, you get maximum shaving of that. And if you are doing at a lower speed, you're not going actually across at the wall. So this is something that he was trying to explain. I don't know how much that is valid.
Dr. Ajay is here, so let us listen to his opinion on that.
Sir, I'm a little disadvantaged because I'm at the airport trying to get into a flight, but I enjoyed all the discussion, whatever I could hear of it. I have two little things to add. What Dr. Bhalla said. Actually, the Japanese have shown that if you do low RPM rota,
low and high.
If you do low RPM rota, am I audible?
Yeah, we are hearing you.
The final MLAs that you get are actually slightly better. So they actually finish ablation at whatever speed and then do another low RPM rotational atherectomy at about 1.2 lakhs or so. And they seem to have a slightly better, MLA along with that. And next, at the next meeting, I'm definitely going to show one rota in which there was a very, 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 ugly dissection. And I'm looking forward to Bali sir's comments on that as to how we managed that particular case. It was actually a rescue. But
you are a
all
master,
points are very, very valid. I feel that the technologies are to be used complementary rather than competitive. Rota, IVL, cutting balloon, etc. in order to get the best possible area. Of course, finances being our.
I think we lost Ajay there. So yeah, I also am aware of this Japanese technology of first doing high speed rota and ending up with a low speed rota, and what they're claiming is that they are getting better or larger MLAs. So
I think it is something same as orbital atherectomy. You go at a higher revolution, probably you get a bigger area covered and slower. Maybe, I don't know. I have not used such a high revolution, neither I done 1.2.
Yeah,
I'm more conservative between 170 to 185 type of a person.
No, I think we use it to modify the plaque and then use some kind of a non-compliant or cutting balloon to further expand the lesion after you crack the calcium. And then, I mean, you're good to go. I've never had, we like I said, we've done so many rotas, but only in very few cases we had to, in addition, use IVL because the calcium burden was that heavy. But I think 95% of the time, that's how we do it.
It's a good idea that once you're finished with that, you do a non-compliant balloon, go at a very 6 atmosphere or see that it is fully expanded. And you can see that there is no indentation on that. Maybe even go to 1:1 balloon. And if you're satisfied with that, go ahead and put in a stent.
Sir, since we are doing 50% of the vessel size, so you have got enough room to, take a 1:1 NC balloon and even go at higher pressures so that the calcium expands. I have not had any challenges. We are not using a larger burr size. We're just modifying the plaque with a 50% burr size and then using an NC balloon to achieve expansion across the entire lesion.
Yeah.
Sir, how do you tackle osteoproximal left and right coronary arteries, lesions, calcific lesions?
Rota is a very
from the guide.
Yeah. See, rota, as you know, once you get once you're negotiating the aortic curve, then platforming it is very important before you start burring it. And you sometimes have to manipulate your guide to, to platform the burr properly before you start burring. So ostial burring is not a very good idea. At least I have not done it. I don't think I can control the rotablation burr safely in this setting without platforming it somewhere in a vessel. So at least I have not done it, and I will not advocate doing rotablation of an ostial lesion.
No, we're talking about ostial left main, or we're talking about ostial LCX and LD?
Ostial left main and ostial RCS, sir.
Okay. I think in those cases, cutting balloon and followed by IVL may be a better technology rather than doing a rotablator. Because you can cause a dissection which can extend into the aorta and cause a problem. So I don't think rota is a good idea there.
Thank you, sir.
So I think we had a very good discussion, sir. And one thing that is would be the conclusion from Dr. Bhalla is that now the days where you learn, de-learn and relearn. So these are the days where technologies are changing so fast that you really have to keep up with them. And let's hope next time we have Dr. Ajay Swami presenting his case. And one more thing is that Dr. Mandeep Bhargav, he has also promised that he'll be either traveling to India in December or before January. So January, I'll be trying that we'll have that, remembering the batches. So the next few batches, we'll try to get their contacts. And in India Live, sir, I'm again trying to have a dinner probably on 16th or 17th. There also we can discuss, present, and even in fact we can plan something with so many intervention cardiologists here. We can have something registry kind of thing, some studies, or even anything that can come up with this association. Almost 180 cardiologists are here, so it is across India. We can think of doing something really great there.
Dr. Smith, can I say something?
Sir, most welcome.
Yeah, from time to time I see in the WhatsApp group people posting, posing questions, difficult situations, that kind of thing, or some showcasing their what cases they have done. So maybe you should ask them to present here, because in the WhatsApp images and all, we can't really see much. Many points may not be there. If at least 1 or 2 per month can be, one of those people can present here, that may be more education.
I also agree, sir, fully, because it becomes difficult for me also to fish out topics and fish out speakers. So there are few like Dr. Bali, which Dr. Bhalla, so I can bank on them. And this is a great suggestion, sir, because primarily we are more concerned with the intervention cardiology, and if we present cases, so this is an open forum, sir. It is not that I am running it. The show is run by every one of us. Anyone can come up with suggestion that I'll be presenting, and I'll be glad to facilitate that.
But Smit, you are doing a wonderful job, and
Sir,
more power to you. Getting all of these people on one platform is Absolutely fantastic.
Really, really. And this job should have been done by PGI.
Seconded Smit. Seconded Smit.
Yeah, thirded. Enthusiastically thirded.
So, Dr. Swami, next time is yours.
Absolutely, Smit. No problem.
Right, sir.
Will do.
Thank you.
And right.
But do consider
Thank you,
organizing a
sir.
PGI conference, maybe at your place. Sorry.
Sir, that we'll discuss in this India live meeting, and I have that in mind, sir. I have recently conducted CSI and Elecon for certification. They both went very well. And let me just inform Dr. Ajay Swami, sir, we did 2 Tewar today. My first Tewar, but 2 Tewar back to back.
Congratulations. Congratulations. Very,
Same
very
case
well.
that I shared, sir. It
Wonderful.
went well.
Excellent. Excellent.
Thank you.
Congrats.
So, sir, we'll definitely have a PGI meeting. We start with a small meeting at India Live, sir. That one dinner night. There we can discuss. In fact, I have formed a registered body. I have even bank accounts. We can even plan for something like a membership, make it legal, make it, people to actually come forward and do some kind of registry work, and all those things are possible. So, because I feel, sir, so much of work we are doing, and
अरे बाबू कितनी बार दिल जीतोगे?
अरे sir,
एक ही दिल है.
I take the hint, sir. Thank you, sir. Sir.
Great.
Right, sir. Good night, sir.
Thank you.
Good night and God
Good
bless.
night. Good night to
Good night,
all.
sir.
Good night. Thank
Good
you
night,
very
Good night,
much.
everyone. Good night.
Good night, Bala.
Thank you, Velu.
Thank you. Thank you, sir. Thank you. Thank you, sir.
Good night, buddy.
Thank you. Thank you so much, sir.
Thank you, sir. Thank you, sir. Thank you.
God bless. Good night.